Good afternoon, everyone. So, my next topic, which I'm going to discuss under congestive heart failure, is different drug classes for congestive heart failure and diuretics. And before I start my video, I want to request you if you like this video and if it is helpful to you and if it is useful to you, kindly subscribe to my YouTube channel, that is Dr. Nitika Pharmacology Discussion. And now I'm going to discuss with you different classes of the drugs for CHF and diuretics. Now, New York Heart Association classification of CHF is class 1 is no limitation on ordinary activities. Symptoms appear with greater than ordinary exercise. Means there are no limitation on ordinary activities and symptoms they appear when there is greater than ordinary exercise is there. Class 2 is fatigue and palpitations with ordinary exercise. With ordinary exercise also there is fatigue and palpitations. Class 3 is fatigue with less than ordinary activity, no symptom at rest. This fatigue and palpitation can occur with less than ordinary activity and there is no symptom at rest. And class 4 of the CHF is when symptoms appear at rest. Now treatment, non-drug treatment or non-pharmacological treatment approach means when we can do the non-pharmacological approach. It can be by physical exercise, we can improve the CHF by reducing the salt intake, by reducing the fluid intake, by reducing the alcohol consumption and liquids, we can treat the congestive heart failure. Now, treatment of congestive heart failure, there are two distinct goals of drug therapy. First is relief of congestion, low cardiac output symptoms, and restoration of cardiac performance. Means the cardiac output is reduced in the congestive heart failure, and which can also lead to pulmonary congestion and peripheral edema. So to treat the cardiac symptoms, low cardiac output symptoms and congestion, the drugs are inotropic drugs. Inotropic drugs are which are beta-1 adrenergic agonistic drugs, which stimulate the heart, thus increasing the heart rate, increasing the stroke volume, increasing the cardiac output. The drug is the digoxin, the butamine, ambrinon, milrinone. Ambrinon and milrinone, these are inodilators. Means they both has the vasodilator as well as the inotropic agents. Inotropic is when they increase the calcium levels in our body, in the smooth muscle, in the cardiac muscle, when they increase the cardiac contractility by increasing the levels of calcium inside the myocardium, and by increasing the levels of cyclic G and P, they cause the vasodilatation. Cyclic AMP and cyclic GMP. Diuretics are the drugs which cause the sodium and water excretion from the body. Thus, they reduce the peripheral edema and pulmonary congestion. The drugs are loop diuretics, that is furosemide and thiazides. Vasodilators, which cause the vasodilatation of the renal, of the veins and arteries. These are ACE inhibitors and angiotensin 1 receptor blockers and hydrolazine and nitrates. These can be venodilators, these can be arteriolar dilators, as well as these can be mixed dilators. Beta blocker is which reduces the heart rate. Means in the chronic cases, we can give this drug. It is not given in acute conditions. It is given in chronic conditions, and it is also known to improve the remodeling of the drug of the heart myocyte, and also it leads to increased release of renin. So when the renin is released, angiotensinogen gets converted to angiotensin 1, and angiotensin 1 gets converted to angiotensin 2. So when it inhibits the release of renin, angiotensin 2 will not be formed, and so there will be vasodilatation as well as salt and water excretion. Arrest, reversal of disease progression, prolongation of survival. means which causes the reversal of disease progression, means which affect the cardiac remodeling. The drugs which affect the cardiac remodeling or which improve the survival of the patient. These are ACE inhibitors, angiotensin receptor blockers, angiotensin 2 receptor blockers, beta blockers, and aldosterone antagonists such as spironolactone and eplerenone is another drug. These are for the reversal of disease progression and arrest. So, in the pharmacotherapy of heart failure, for the acute conditions, this is the acute decompensated heart failure. The drugs are diuretics, sodium proside, nitroprusside, which is the vasodilator, mixed vasodilator, and inotropic drugs like dopamine and dobutamine. Another newer agents can be, these are inodilators, phosphodiesterase inhibitors, and the seretide. Chronic, the drugs for the chronic uh, compensated heart failure are drugs, diuretics, ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, hydrolazine, and nitrates. This hydrolazine and isosorbate dinitrate can be given. So, in the chronic cases, we give these drugs. So, now heart failure is what? It is the reduced cardiac output. Reduced cardiac output means then there will be release of renin and there will be stimulation of the sympathetic overactivity. So now when the renin is released, angiotensinogen gets converted to angiotensin 1. And when the sympathetic activity increased, that is beta 1 receptors are stimulated and alpha 1 receptors stimulated, that will lead to vasoconstriction. Angiotensin 1 gets converted to angiotensin 2 with the help of angiotensin converting enzyme. And it also leads to increase the release of aldosterone in the body. And aldosterone is responsible for cardiac remodeling and sodium and water retention. And this vasoconstriction will lead to increase in the total peripheral resistance of the body, increase in the afterload, increase in the elevated cardiac pressure. And this increase in the afterload, increase in the elevated cardiac pressure will again lead to heart failure. This is what is the compensatory mechanism and what pathophysiology of the heart failure, how it acts. Now, reduced cardiac output. To increase the cardiac output, the drugs are inotropics and digoxin. Digoxin inhibits the sodium potassium ATPase pump, and basically it also increase the release of calcium inside the cardiac myocyte. So increase the cardiac contractility. ACE inhibitors will lead to decreased formation of the angiotensin 2. Angiotensin receptor blockers will act at the level of angiotensin 2. They will act at the AT1 receptors. So the action of angiotensin 2 will not come. Diuretics are which cause the sodium and water excretion from the body. They do not cause the sodium and water retention. Vasodilators are which cause the vasodilatation of the arterioles and veins. So vasodilators can be given. Spironolactone is the drug which is the aldosterone antagonist, so it will antagonize the action of aldosterone, so there will be no sodium and water retention, and cardiac remodeling can also be prevented. Beta blockers act at the level of increase in pathomimetic activity, means they will block the action of beta 1 receptors, so there will be no increase in the heart rate and increase in the cardiac output. It is used in the chronic conditions. This is again the same thing, the pathophysiological mechanisms of the heart, that is heart failure. It is the reduced cardiac output. Reduced cardiac output can lead to increased release of renin, stimulation of the sympathetic nervous system. When the sympathetic nervous system is stimulated, that can lead to vasoconstriction. And renin, it will lead to formation of angiotensinogen 1 from the angiotensinogen. And angiotensin 1 gets converted to angiotensin 2 by ACE enzyme. And this angiotensin 2 will lead to increase in release of aldosterone. And then that can result in the cardiac remodeling. and sodium and water retention. And this vasoconstriction of the arteries and veins can lead to elevated cardiac filling pressure. So the drugs again, which act at these levels, at the reduced cardiac output, the drugs acting are inotropics and digoxin. Beta antagonists are the which act at the sympathetic nervous system level. ACE inhibitors at the level of angiotensin 1 conversion to angiotensin 2. Aldosterone antagonist, spironolactone at the level of aldosterone action. AT1 receptor antagonists are the receptors which block the action of angiotensin 2. Diuretics, which will act at the sodium and water retention level, that is, they will increase the release of sodium and water excretion. So this is how the drugs they act. Now, diuretics. Diuretics can be of three types, which can be used in the heart failure. These are loop diuretics, thiazides, and potassium-sparing diuretics. Loop diuretics can be used in the acute decompensated heart failure. Thiazides can be used in the mild heart failure. And in the chronic heart failure with low ejection fraction, we use potassium-sparing diuretics. Action, mechanism of action is they are sodium chloride, potassium chloride transport in extending loop of Henle. They act at this level. And thiazides, they are sodium chloride co-transport in distal convoluted tubule. And this potassium-sparing diuretics, they inhibit the aldosterone and they block the sodium conductance. Adverse effect of loop diuretics is they cause hypokalemia. Of thiazides also they cause hypokalemia, and potassium-sparing diuretics is they cause the gynecomastia. Now, this loop diuretics can be combined with thiazides to see the synergistic effect, and they can be given along with diuretics to avoid hypokalemia, potassium-sparing diuretics. And the drugs are furosemide, torsemide, bumetanide, loop diuretics. Thiazides are hydrochlorothiazide, and potassium-sparing diuretics are aldosterone antagonists also. These are spironolactone and amiloride. Now, diuretics, they relieve the pulmonary congestion and peripheral edema. These agents are useful in reducing the symptoms of volume overload, including orthopnea. Orthopnea is when the patient suffers from breathlessness while lying down position. When he lies down, he suffers the breathlessness and gets relieved up by sitting in the sitting position. Proximal nocturnal dyspnea is the dyspnea which occurs in the night time. After 1 to 2 hours, the breathlessness is there in the patient and the patient disrupts from the sleep. Diuretics decrease plasma volume and subsequently decrease venous return to the heart. Means they will decrease the fluid overload, so that will lead to reduced venous blood flow. That will lead to reduced venous pressure, reduced venous return to the heart. They also decrease the cardiac workload and oxygen demand. And they also reduce the afterload. Diuretics also decrease the afterload by reducing the plasma volume, thus decreasing the blood pressure. Now, diuretic resistance in heart failure. When there's excessive dietary sodium intake, that can lead to diuretic resistance. When there is non-compliance with medical regimen, when excessive intravascular volume depletion is there, hypotension due to marked diuretic or vasodilator therapy. Means when there's excessive intravascular volume depletion, or there can be hypotension due to marked diuretic or vasodilator therapy. Over and chronic use of non-steroidal anti-inflammatory drugs, hormones, corticosteroids, and leucories that can develop the diuretic resistance. Decreased absorption of diuretics due to gut wall edema or renal pathology. All these can lead to diuretic resistance in the heart failure. Thank you. That's all with the classes of the drugs, pathophysiology behind the development of the congestive heart failure, and diuretics. Thank you. That's all. Be happy, be healthy, be blessed. Happy learning. Kindly subscribe to my YouTube channel if you like this video. Thank you. Happy learning. Thank you.